Hi, in this lecture, we're going to learn about the thyroid gland and the parathyroid gland. So the thyroid gland is anterior to your trachea. It's below your larynx, and you might be able to feel your vocal, it's called your laryngeal prominence, but what you might see is your Adam's apple, so to speak. It's right below that. So a lot of times when you palpate it, when you swallow, you might be able to feel it. So you can see the larynx right here, and you can see the thyroid gland right below. It's kind of a butterfly-shaped gland. It has two sides of it, and these two lobes are connected by this thing in the middle called the isthmus. Now, if we look at the thyroid gland, it's made up of follicles. So if you look at a microscope, a histology view, lots of these round structures called thyroid follicles. Now, the follicles are formed by follicle or follicular cells. And if you look closely, you should recognize what kind of cells these are, what kind of tissue. You'll notice that they're simple cuboid epithelial tissue. So they have that nice round nucleus. So you have the follicle lined with follicle cells, and these follicle cells make and store the thyroid hormones. In fact, I've read that the thyroid gland can store roughly 3 months worth of hormone inside of it. So if those cells should stop working, you probably would be okay for 2 to 3 months because it stores so much in it, and it stores it inside in what's called the colloid. So this colloid is the stuff inside. It has thyroglobulin molecules, which is the thyroid hormone. And there's two we'll be looking at. They're called T3 and T4. There's an amino acid tyrosine, and you need a lot of iodide in order to make the hormone. So here's a better view of the thyroid gland. We can see the two lobes. We have these follicles that are formed, and then these are the follicle cells that form the follicles. Now, we'll notice between the follicles are these cells here called parafollicular cells, or we call those C cells. And we'll look at their function shortly. Right now, we're going to focus on the two main thyroid hormones. So you need the amino acid tyrosine, and you need to make sure you get iodine in your diet. And it's usually not too much of a problem because most of our salt is actually iodized salt. It's in several different types of foods. So these hormones are made. Now, they are transported on proteins. So they do have these transport proteins called thyroid binding globulin. A globulin is a type of plasma protein, or albumin is another plasma protein. And so what happens is they're made inside the cell. The follicle cell is going to take up the iodine and take up the tyrosine. It's going to make the hormones where it's stored until it's eventually going to be released. And the two hormones are called thyroxine and triiodithronine, which we just say T4 and T3. Now, as far as these hormones, momentarily, let me go back for 1 second. It does appear that T4 may be more of a pro-hormone. A lot of T4 is released, but when it binds at the target cell, it becomes converted into T3. So T3 may be the active form. So what are these hormones do? Well, I'm sure you all know they control your metabolism, right? When we think about metabolic rate. And just understand that almost every cell in your body has receptors for the thyroid hormones. So they really affect almost every cell. But one of the main things is they control your basal metabolic rate, just your metabolism, right? If you're to lay in bed all day in a nice, comfortable room, a lot of that's just those sodium potassium pumps that are always pumping, right? Pumping the potassium back in and kicking the sodium out and the enzymes. So critical for that. Now, every time we generate ATP, we produce heat because we're about 40% efficient. So we lose a lot of heat. So it also is calorogenic, meaning it produces heat. It affects the adrenergic receptors. Remember, these are the receptors that bind norepinephrine. So it's going to bind norepinephrine. It's going to do things to your heart, like increase your heart rate and how strong it contracts and raise your blood pressure. And it's critical for everything, for normal bone and muscle growth. It has effects on our skin, on our reproductive system, and our digestive system functioning. So as far as how it's released, the factors, we're going to come back to negative feedback. So what we're seeing here in our pictures, we have our hypothalamus. And remember, the hypothalamus releases TRH, and TRH is going to go to the anterior pituitary gland and trigger the release of TSH. These were tropic hormones. TSH goes to the thyroid gland and triggers the release of T3 and T4. So as those levels go up, they're going to send negative feedback to turn down, right, to lower TRH and then lower TSH. So it's a negative feedback loop. Understand there's some other factors that increase your risk of thyroid hormone. When you're pregnant, it tends to go up, and cold weather. Mainly if you're like in Maine over a cold winter. It's not just like it's cold one day, so you release more. But those factors can also trigger the release of the TRH. And then again, if our thyroid hormone levels are too low, so we'll go to this, like what if the levels are too low? Then we would expect to see an increase in TRH and an increase in TSH. So anytime we have these hierarchies, these hormone hierarchies, it's important to understand what's happening so you can kind of predict the effects. So for example, if we look at, we know that TRH comes from the hypothalamus and it goes to the anterior pituitary. We'll just write anterior pit. And releases TSH, and then TSH's job is to go out to the thyroid gland and trigger the release of T4 and T3. So what if you were hypothyroid? You know, there's several different causes. So let's say that our levels of T4 and T3 are too low. But we do blood work, and when this happens, we notice that our TRH levels are increased, but our TSH levels are low. And we notice that these are low as well. So notice that these are too low. So we would expect, right, if our thyroid hormones were low, we would expect the feedback loop to come up and to increase TRH. Okay, that makes sense. But if we increase TRH, then what should happen to TSH? Well, hopefully you're like, well, TSH should go up, but it didn't. It stayed down. So I know in this case that the hypothyroidism is due to a problem in my anterior pituitary gland because it didn't respond. So whenever you're having these blood levels tested, especially any hormone with a cascade like this, they're going to test all of them. For thyroid, they tend to look at TSH and T4 and T3 to try to get a sense of what's going on with that. When we look at disorders in the thyroid, just like other endocrine disorders, we can have hypo and hyper. So hypo could be your thyroid gland isn't working, right? It's just not cranking out the hormone. We just said maybe it's a problem in the anterior pituitary gland with TSH. You could have a problem in the hypothalamus with TRH, or maybe you're not getting iodine in your diet. Okay. So what happens is anytime a cell or tissue works harder and harder and harder, it gets bigger, right? And so a goiter, you can see one here, is an enlarged thyroid gland. So it's a sign of hypothyroidism. It's a sign that the thyroid's working really, really hard. So it's more like a sign of a problem with it. Now, you can have this occur as an adult. It's called myxedema. It's kind of like a generic term for hypothyroidism as an adult, whereas cretinism is hypothyroidism in childhood. Now, the issue during childhood is growth and development will be affected. So a lot of times the child will be smaller and it could have neurological consequences and not proper development of the brain. Whereas hyperthyroid is too much thyroid, and so this is commonly called Graves' disease. It's a condition of hyperthyroidism. In fact, you may have heard of one of the common diseases that's hypothyroidism is Hashimoto's thyroiditis. And these tend to be autoimmune disorders as well. Graves is definitely an autoimmune disorder, and Hashimoto's can be as well. So how do you know if you have hyper or hypothyroidism? Well, you can see here all the signs and symptoms. So if we're looking at the hypo, it definitely affects our hair, skin. Usually you're intolerant to cold, so you're going to feel cold more often, probably going to be tired, have brain fog. It will cause weight gain because your metabolism will slow down. It can affect your digestive system and cause constipation and can cause problems if you're trying to conceive. Whereas hyper, right, if there's too much thyroid hormone, it has kind of the opposite side. You're going to be more restless and irritable. You're going to lose weight. You might feel too hot all the time. So you're always like, it's really warm in here. You can have hair loss. The eyes actually can start to bulge slightly as well, which is what you kind of see in this picture, classic with hyperthyroidism. So if it's hypo, the treatment is to give you the hormone. It's called Synthroid usually. So they can usually give that to you. If it's hyper, a lot of times they go in and they can try to remove the thyroid gland, and then they put you on Synthroid so that it doesn't produce too much hormone. Now, the other hormone that's made is calcitonin, and that comes from those parafollicular or those C cells that we looked at previously. These are the cells that are between the follicles, and so there tends to be little clusters of these things, and it's fine to call them C cell, and it might help you remember they make calcitonin. Now, we learned calcitonin previously when we looked at bones because it's really important at controlling blood calcium levels, and what it does is it puts that calcium in your bones, so it makes your bones stronger. So we have our normal homeostasis for calcium. When you take in a calcium-rich diet, you're eating your yogurt, drinking your milk, your calcium levels go up. That's the trigger for calcitonin. So it's a humoral stimulus, right? It's for your blood calcium levels. And then what it does is it tries to bring the calcium levels back down by taking that calcium and putting it into your bones. So it primarily acts on the skeleton. It can do a little bit the kidney and small intestine, but we're going to focus on the skeleton now. And that it's going to inhibit the osteoclast. Remember, they're breaking down bone, but it's going to activate the osteoblast. So it's going to take that calcium and it's going to put it in your bones to make your bones thicker and stronger. So this is obviously more important during childhood. In fact, as we get older, right around 25 to 30, we lose the ability to start really putting calcium into our bones, which is why it's important to do that, especially if you're younger, and then to maintain it as you get older. Now, PTH is the antagonist hormone. It has the opposite effect, and it has these little parathyroid glands that are on the back of the thyroid. So there's usually 4 to 8 parathyroid glands. This is another protein hormone, and the cells that make this are called chief cells. And so you'll see these little pockets of your parathyroid glands scattered amongst those thyroid follicles. Now, this is kind of interesting because these were accidentally discovered. So PTH's job is to maintain blood calcium levels. So if we have our normal, if you're not eating calcium and your blood calcium levels fall, that could be deadly. We know calcium is very, very important. So if the calcium levels fall, then the chief cells release the PTH, and then its job is to raise it again. So, we know calcium is critical for several things. We know that we need it for muscles to contract, right? If you don't release calcium, then smooth muscle, cardiac, skeletal muscle, they won't contract. If your cardiac muscle doesn't contract, then your heart doesn't beat. We know we need it for blood clotting. It's a second messenger for hormones, so it's critical for hormone release. And you learned back last unit that we need calcium to release neurotransmitters, so it's very, very important. So I mentioned it was accidentally discovered because what happened is they would have individuals who had issues with their thyroid glands, and they would do a thyroidectomy. They would take out the thyroid gland, and some patients died. I'm like, what's going on here? And then they found, look, there's these other little nuggets in here. Because what would happen is if you took it out and you took out the parathyroid glands, if your calcium levels dropped, you had no way of raising your blood calcium levels, so you'd probably go into cardiac arrest and die. So now they're aware of those glands, they leave them behind so that we don't have those issues. So if our blood calcium levels fall, this is life-threatening. We've got to get that calcium, so we got to go take it out of our bones as the number one place we go. And so when PTH is released, it's going to stimulate the osteoclast, right? It's going to take calcium out of our bones because if we don't, we're going to die. It also is going to go after our small intestine and our kidneys. It actually goes into the small intestine, whereas most absorption of all your nutrients happens in your small intestine. So it really tries to pull any calcium out of anything that you might have eaten. And it also targets the kidney, where it tries to hold on to calcium so you don't lose it in your urine. So it has a really important 3-prong attack. Now, when we're looking at hyper and hypo, we don't really see hyperparathyroidism too often. The issue is hypo, like I said, if it's accidentally removed with the thyroid gland. But what happens if you don't have enough of this hormone and your calcium levels fall, you're going to have some problems. So what happens when our calcium levels are too low is it affects our sodium movement movement into a cell, it actually makes it easier for sodium to get in. So your cells become too excitable and you can get muscle spasms that can develop as well with this. So when we're looking at these two hormones, PTH and calcitonin, they both have a humoral release. They're critical. They're humoral. What they're looking at is blood calcium levels. If blood calcium levels go up, that's the signal to release calcitonin. The effect is to lower it by putting it in our bones. If our blood calcium levels fall, that's the stimulus to release PTH. PTH takes it out of our bones, and our blood calcium levels return to normal. So that's the action of our calcitonin and our PTH and the end of this lecture.